Imagine a patient presenting with classic ischemic chest pain. This is the baseline scenario often found in high-stakes clinical exams, designed to test your immediate reaction to a cardiac emergency. The common instinct, the standard reflex for most nurses, is to immediately reach for nitroglycerin or a loop diuretic like furosemide to decrease the heart's workload. However, the chart contains a specific diagnosis that changes every clinical priority: hypertrophic obstructive cardiomyopathy, or HOCM. In this specific anatomical context, acting on those standard angina instincts leads to a rapid, fatal cardiovascular collapse. When presented with the typical four-choice format, option 2, beta blockers, emerges as the only physiological path to survival for this patient. Surviving this scenario requires a shift away from typical ischemic protocols, focusing instead on how HOCM's unique anatomy alters the physical impact of the medications we provide. In a HOCM heart, the ventricular septum is significantly thickened. It swells inward, narrowing the left ventricular outflow tract. During contraction, blood flow pulls the mitral valve forward until it slams into the septum, sealing the exit and stopping blood flow entirely. Beta blockers provide life-saving intervention by slowing the heart rate. This increases diastolic filling time, allowing the ventricle to fill with a larger blood volume, the preload. This acts as a physical wedge, propping the outflow tract open and keeping the valve away from the septum. Beta blockers also provide a negative inotropic effect, reducing the force of the squeeze, so the mitral valve isn't violently sucked into the path. By maximizing fluid volume and softening the mechanical contraction, beta blockers physically maintain the heart's exit pathway. To understand why the other choices lead to arrest, we have to look at the mechanics of nitrates and vasodilators. As defined in these core nursing concepts, preload is the volume of blood in the ventricles at the end of diastole. Vasodilators cause systemic expansion of the vessels, which drops venous return and effectively destroys that critical preload. Without that internal volume to keep the chamber walls apart, the HOCM heart allows the ventricle to cave inward, locking the mitral valve against the septum, creating a total mechanical obstruction. Blood flow stops, resulting in immediate syncope, systemic failure, and ultimately cardiac arrest. Diuretics like furosemide cause the same catastrophic failure. By drawing the patient out, you remove the fluid volume that the HOCM heart relies on to stay open. In these patients, blood volume acts like a stent. If you use medications that dilate or dehydrate, you remove that critical stent and allow the heart to obstruct itself. The clinical priority for HOCM is clear. This heart requires high fluid volume to function. Anything that decreases that volume is a direct threat. For the purpose of the exam and the ward, remember, HOCM is incompatible with vasodilators, nitrates, and diuretics. Maintenance of an open outflow tract depends entirely on aggressive hydration and the consistent use of beta blockers. When you see this patient profile, you bypass standard ischemic choices and confidently select the beta blocker. By centering your care on the unique fluid requirements of the HOCM heart, you can accurately navigate the exam and provide safe, effective care at the bedside.